this talk, and I will note the clock time, so you can do extra 2 minutes.
Okay, great, thanks. And don't judge me on how I communicate the mathematics, given what we just heard. So I'm going to give a bit of an overview of some of the work we're doing in this sort of digital twin space. It links to cancer, but it's mainly about retinas, and I'll come on to why that's hopefully relevant to what the interest of this workshop is. And I thought I'd start. This is the great thing about speaking on the second day, is you can change all your slides in response to what happened on the first day. So this sort of chat, it's like thinking about what a digital twin is. And I'm really keen for this stuff to end up in the clinic ultimately, somehow. And having worked in sort of medical devices and healthcare interface, technology interface for a while, it is really hard to get anything into the clinic. I think we all probably appreciate that. I don't think anything I've ever done has ever really truly ended up in the clinic in the way that I'd either hoped or dreamed or whatever. So there's this big gulf, translational gulf, between what we make and then getting doctors to use it in clinics. And so I'm often trying to interface with my clinical colleagues and go, this is a really good thing, you'd love this. And there's a lot of conservative skepticism that I see in response. So I often say, you're already using digital twins in some form in the clinic. And the one that I often use is the idea of drug dosing. So if you're in a cancer clinic, if you're an oncology nurse, you weigh your patients, you then get your drug, you then get a dose corresponding to that weight measurement, and then you update the dosing with a prediction about what the concentration will be of that drug in that patient, and then you update it. So that is a very, very simple form of a digital twin, I would argue. And I think it meets the criteria that we were talking about yesterday, because you're updating, you make your prediction, it's individualized to the patient, and it's incredibly simple. So you're literally just saying concentration is a dose per unit kilogram times the mass, and then you'll make your prediction on that basis. And you could vibe code this if you wanted to. I mean, something in Python, I don't know. But we're probably more thinking about something a lot more sophisticated. And this is kind of where we started this journey, is with MRI. So doing DCE MRI, when you inject a contrast agent and you try and predict delivery characteristics within individuals' tumours. So estimating blood flow, vascular permeability, those kind of things. And you make these lovely maps that you then try and summarise and use eventually to individualise some aspect of the patient's therapy. But that's never quite happened, but hopefully in the future it will. And we're really interested in understanding these mechanisms on a sort of finer scale. With MRI, you only get very limited access to physiology, to the blood vessels in someone's tumour. You can just see where the contrast agent ended up, and you have to do an inverse bit of modelling to try and infer what the blood flow is. So we did some work looking at animal tumours. These are subcutaneous tumours, colorectal cancers grown on the side of mice. And this is just when 3D microscopy, light sheet, that kind of thing was becoming quite fashionable. Labelled the blood vessels, reconstructed the vascular network, and then did some fluid dynamics analysis to try and predict what the vascular pressure in the tumours were, the blood flow, and things like the interstitial fluid velocity. In individual mice, just to try and understand these characteristics, and there's a can we do it kind of problem. Very much not something you can do in the clinic. You have to take the tumour out and do the 3D microscopy, but it's quite an interesting exercise preclinically. Once you have that kind of baseline prediction of blood flow, you can then overlay delivery of material. So in this case, it's the contrast agent that we use in MRI that we're trying to predict the delivery as a validation step. But that could equally be a drug with particular physical characteristics. So kind of digital twinny, but mouse digital twinny, and you have to take the tumour out. So not really particularly useful for clinical application. So, segue to retinas. So we were doing this work, and I was approached by Ranjan Rajendram, who's an ophthalmologist at Moorfields Eye Hospital, who showed me these images that he can take of the retina. And I'm showing a 2D projection here, but these are 3D. This is optical coherence tomography angiography images. And you can just get this exquisite detail from individual patients, showing where the retinal artery and veins come out of the optic nerve. They then bend around the macula, which is the structure for detailed vision. And you can basically segment these vessels out fairly easily. He's interested in diabetic retinopathy, which is when you have diabetes, late stage diabetes, you start getting loss of microcirculation and regions of ischemia forming. And then angiogenesis, just like you get in cancer, they become hypoxic, so you get this kind of re-establishment of the blood vessels. They're treated with VEGF inhibitors, which is very similar to in cancer. So there's a lot of overlaps between this as a condition and cancer, which sparked my interest a lot further. He's interested in just quantifying this stuff. I'm more interested in, what is this due to blood flow in these networks? How does it change delivery characteristics? But the key question is, how do you segment these blood vessels into a usable format? And when I say usable, like a spatial graph, so nodes connected to edges, in the way that we can do the same kind of fluid dynamics analysis as I showed you in the mouse models, and then hopefully do something a bit more clinically useful. Now, just to say one way of doing this, the usual way of doing segmentation is to get a whole load of master's students to sit for hours painstakingly painting these things on images. And there's entire PhD projects that are basically consisted of doing that, which is pretty awful, I think. I'm glad I didn't have to do that these days. So we've tried taking a different approach, and I'll come on to how this works at the end of this narrative, but just to say the starting point is to try and simulate blood vessel networks. So to develop algorithms that can make blood vessel networks, so veins and arteries, fully connected in a manner that looks like these retinal vascular patterns. This is the end result, which I'm going to explain how we do it. So you can hopefully see that there's some good correspondence between the clinical one. This is an OCT image, this is the simulation. It extends to the whole retina, so it's not just the region that I've shown you. And this is using a technique called constrained constructive optimization. And what you do is you start with a regularly spaced lattice, which are these dots, and you start with a feeding vessel. You then kind of arbitrarily, based on minimal distance, connect those lines to the lattice points. So you're kind of starting to create a network. You then set the radii of these vessels based on what you define as the required flow per unit volume or area within each lattice point. Use quasi-flow and then mass conservation to kind of propagate the radii up. So you can see this vessel's only feeding one of these lattice points, whereas these guys are feeding more, so they're thicker. So you can kind of see that propagation step of the radii. And then you do an optimization that then sets the location of each of the nodes in the putative network based on minimizing the pumping cost, so the power required to get blood through the network, and the cost of having those blood vessels in place. So there's a metabolic cost in just having a lot of blood vessels, so you need to minimize that, and you want to minimize the pumping cost as well. And if I just go between the two, you can see the effect of that optimization, and it suddenly looks blood vessel-y once you apply this optimization. It's got this kind of qualitative sort of network feel to it. And we then iterate across multiple scales. So you start big, and then you scale it down to the finest scales, whatever you want the smallest vessel length to be. So that's how we created the retina networks in 2D, although projected onto a hemisphere. And that's shown here. So this is one of our examples in projected onto a sphere from the retina. We've also tried it in lung. So this is from CT data from a real lung, where we've sort of got the mesh at the outside of the lung and the sort of feeding vessels and airways, and then grown candidate distributions of vessels into that. Also doing it on the kidney. So there's lots of kind of potential applications. Although why bother is probably the next question you have. I'll come on to why bother in a second, but the other thing to note is that you can then, knowing the kind of physiological ranges for each of the parameters you do to grow that network, you can then make hundreds, thousands, millions of candidate distributions for each retina. So here's the key bit, is where we bring in deep generative learning. You may have noticed that people are keen on deep generative learning. You've probably heard about it in the news. This is basically using a very similar technique to the one that can generate images of astronauts riding unicorns, which you've probably all done. But this is using latent diffusion modeling. And what we can do is take our simulated vessel networks, and we can give it the style, so the look, the texture, the contrast of one of the clinical image data in an unpaired way. So we just need a big library of our simulations, big library of medical images. We can train the neural network to learn those two distributions and then the mapping between them. And this is a two-way thing. That's the key bit. So we can give our simulations the look of medical images, and we can also give the medical images the look of the simulated retinas. I'll skip through this bit for the sake of time. And what that means is because we've got all of the physics embedded in the simulation space, we can then infer that same physics from the structure of the medical image space. So it's a two-way mapping. So this is physics-informed deep generative learning because we have the physics embedded in that simulation space. What you also get is a segmentation for free. So rather than having our students laboriously manually segment, we can just pull out the segmentation space from, because we know the mapping between clinical image and simulation space. And it turns out this is quite an effective way of doing the segmentation. So publicly available data sets of STARE and DRIVE, we got pretty much state-of-the-art segmentation efficiency with no manual labeling at all, to the relief of MSc students everywhere. It also means that we can start inferring the physics from individual patients. So predicting the delivery of fluorescein, which is a contrast agent used in ophthalmology fairly routinely. We know where the vessels are, we can predict what the blood flow is, we can then predict how quickly fluorescein is going to accumulate there, and we can compare that back as a validation step to the actual patient data and see how well we're doing. We then do stuff like predicting the onset of diabetic retinopathy. So this is a simulation currently, but it's future work to actually apply this in the clinical situation. But this is a simulation of a normal retina, and we can start eating away the vasculature in a way that's consistent with diabetic retinopathy, early stage at the edge, and then it starts progressing towards the center. And we can compare that back to the typical presentation at this stage that you see in patients. We can see what the effect on blood flow is. This is without thinking about any kind of blood vessel regulation, but we can see, okay, what would happen to the flow under these situations? Is there some way we can maybe detect early onset of diabetic retinopathy just from the change in the feeding arteries, for example? We can also do things like predicting oxygenation. So this is using a Green's function approach. So we can take our blood flow, we can infer from it some transport properties of oxygen, and we can say, okay, this region here, it's fed by these blood vessels. How likely is it to become hypoxic? How likely are we to see cell death? What's the impact on the patient's vision likely to be further down the line? So the idea is this is hopefully a way of really embedding a full kind of digital twin of each patient, each diabetic retinopathy patient, and then predicting the progression of their disease. So I will stop there, and I think I'm way ahead of time, which is unusual for me. Just to thank all my colleagues, particularly at the UCL Centre for Computational Medicine, Rebecca Shipley, she's my main collaborator who does most of the maths, but also all the other postdocs and PhD students that have worked on this. So thank you very much.
Excellent.
So how much of the diagnostic power comes from seeing the progressive features in patients with late-stage diabetic retinopathy?
Yeah.
And how much comes from a prediction of what features you would see and therefore what you look at the start?
Okay, I think I understand the question. So currently, ophthalmologists get an image, the one I showed you, and they go, I think that's roughly a 10% loss of microvascular bed. And that is all they get. So that is the strength of the current clinical standard for the diagnostic. So that's why my colleague is keen just to have some quantitative measure that should be in there. They then use that to guide what therapy should come next in ways that I'm not entirely sure about. Does that sort of answer your question? Or?
Let me ask it in a slightly clearer way. So if you're looking at a patient who's got late-stage diabetic retinopathy, you can see what's gone wrong.
Yeah.
But that's different from cause. And if you're doing the diagnosis at the start and interested in disease progression, then rather than going, it's probably going to go there, it's gone there.
Yeah.
That's quite different from treatment, particularly preemptive treatment. And then you're looking at markers at the start of the treatment journey rather than at the end.
Yeah, and this is kind of speaks to being guided by the intricacies of the healthcare system. So currently, my friend at Morpher's Eye Hospital sees these people come in and they already have lost some vision. They've already got sort of this presentation of disease. It's almost a bit too late for them then. And the best thing to do is to see it early and then have dietary interventions, for example. And the way to do that is to use the OCT systems that are currently in Specsavers and Boots and the high street opticians who've got very much similar systems. We can start kind of putting this kind of technology in principle. I'm saying that boldly, I'm sure that's going to happen. And then catch this early and find some sort of mechanistic link. That's what I think the power of having a physics-informed AI approach is that you can get at mechanism. So it's not a purely kind of correlative exercise. You can say, oh look, there is blood flow changing in this region. Therefore, this mechanism might then be, this thing might be happening. This understood mechanism might be happening. So, and at an early stage. So yes, it's complicated, but partly because of that way healthcare is set up. Yeah.
Thank you very much. I'm curious, in your physics, do you include the curvature of the area?
The curvature
Yeah,
of the eye, yes. To an extent, it's much easier not to. It would be lovely to not have to, because growing on a hemisphere takes a lot more thought than growing on a plane. So yeah, it'd be nice not to have to. It's a work in progress to understand if you have to or not.
Yeah. Do you have any vessel remodeling?
Not yet.
Okay.
So we need that, and that's where my interest overlapping with cancer is, because
What about the non-linearity, the plus-eye flow? Because at that scale, there's big correlation with a hematocrit vessel size.
Yeah.
So it's not just plus-eye flow.
Yeah, and we do sneaky tweaks with the viscosity to kind of account for the non-Newtonianness and that kind of thing.
Do plasma skimming as well? Because that.
Yeah, we can embed all of that stuff. Yeah. Hopefully we're sort of within the right ballpark for the predictions that we make, and it seems to be from comparing with the fluorescein delivery that we're in the right ballpark. But I think there's a lot of finessing we could do. Yeah.
So 2 questions. One is with the OCT. Do you have the other eye?
Yeah.
And have you looked at it, and how similar are they? And does that give you do you get more diabetes in one eye than the other? And then the other thing is, when you do these synthetic networks, how robust is the measurable outputs? Like, say, if you move some of the nodes that you use to build them, and you move them a bit, is the actual flow, the oxygen delivery, i.e. how accurate does it really need to be a good description of what you're trying to sort of match it to, if that makes sense?
Right. I think we do have matched both eyes. So in most situations, patients will have both eyes scanned to compare against. Accessing clinical data is really tricky in the UK. So we're kind of drawing on all sorts of sources to try and overcome that. But yes, comparing different eyes is something that Ranj, the ophthalmologist, is really interested in, because in some patients, one eye progresses and the other doesn't. Why does that happen?
Yeah. And I'd also be curious to know how similar they are or not.
Yes. And also, so we're proposing a study where we couple this with MRI as well to get the vasculature in the head and the feeding vessels in the neck. And is there something going on there on either side that's different? So yeah, there's all sorts of interesting things we can do. What was the other question?
About sensitivity analysis
sensitivity,
in terms of the way you generate your synthetic networks.
Yeah, so the win is that we get a quantitative measurement of some form, which we hope is accurate. How sensitive that is, we've got to do a big sensitivity analysis to find that out, which we've not done yet.
Excellent. We'll have one last question and then...
With the objective function you use to generate the synthetic network, essentially you minimize the dissipating loss and some metabolic cost function. But this is applicable to, I don't know, some piping system that you try to push fluids through the system. But for vascular networks, it has like a more important role, which is to distribute oxygen. So is it possible to include that in objective function, will it change how this?
So, yes, and the idealized generative function that we used is idealized. So for pipes, so it's Murray's law that we use, and for pipes has an exponent of 3, whereas in real life it's about sort of between 2.3 and 2.7, something like that, and it's different between arteries and veins, and there's all kind of things like that. And also that the retina is specialized, for some reason, the inner vasculature is at the front of the eye, so light has to travel through it to get to photoreceptors, which makes very little sense, but it's optimized to allow that to happen. So there are probably nuances in the way that we do that generative simulation for each individual organ. Having said that, once we have an AI model that can predict this stuff and extract it directly from the patients, we don't need that generative algorithm anymore. We can just use that AI approach, and it will have embedded all of those nuances that are particular to each retina. And that's another exciting thing, is we can start understanding those individual organ differences from the idealized physics, right? If that makes sense. Yeah, okay.
All right, well, thanks, Simon, again.
Thank you.